Hello, everybody. This is Professor Barrett, and this is going to be a lecture about um, coronary artery disease. Because the topic of coronary artery disease and acute coronary syndrome is so large, there's one slide deck, but I'm going to break the lecture recordings into two separate parts. So this is going to be for coronary artery disease. And then acute coronary syndrome is going to be the next lecture available. Okay, so just talking about coronary artery disease and chronic stable angina. All right, so what is cardiovascular disease? It is a very generalized term for any kind of disease that affects the cardiovascular system, right? So, cardiac diseases or cardiovascular diseases are the leading cause of death in the United States. The most common the most common cardiovascular disease is coronary artery disease. So we abbreviate that CAD. Um, CAD can be asymptomatic or it can be symptomatic. And the symptomatic form of CAD is called chronic stable angina, which means the patient has chest pain, right? And then acute coronary syndrome, which we're going to talk about in the next lecture video, covers unstable angina and then the two different types of myocardial infarction, which are STEMIs and non-STEMIs. All right, but coronary artery disease or CAD has a very profound effect on perfusion, right? So perfusion is the ability of all the tissues and organs of the systemic circulation to get oxygenated blood. And coronary artery disease, or what we commonly refer to as hardening of the arteries, makes it difficult for the body to be able to perfuse tissues properly. Okay. It negatively affects the heart function, it impairs cardiac output, and all those things together mean that tissues are getting less perfusion. Okay. So, what is coronary artery disease? Well, basically, it is, like we just said, hardening of the arteries. So, there are fatty deposits, which are called atheromas, which get formed in the coronary arteries. So, the very beginning of that starts with damage to the lining of the arteries, which we'll look at in a minute. Coronary artery disease goes by many other names, arteriosclerotic heart disease, cardiovascular heart disease, ischemic heart disease, or coronary heart disease, all the same thing. Okay. What all those names have in common is they're describing the process of hardening of the arteries, or atherosclerosis is the medical term for the hardening of the arteries. Okay. So it starts when the endothelial lining in the arteries starts to get inflamed or damaged because of things that we talked about, like in the other lectures that you've already listened to, where we talked about things like hypertension over time, high fatty deposits, high cholesterol levels, high blood sugars. These things over time cause inflammation and wear down the lining of the artery. Once there's an injury to the lining of the artery, which is there to protect clots from forming, right? There it has a natural like antiplatelet coagulating function to it where it should keep the platelets and blood cells from sticking together. But when there are injuries in that endothelial lining, then the lipids that are in the bloodstream start to fill in the areas where the endothelial lining is damaged. And then other platelets and calcium deposits start to form on top of that. And that forms a plaque that just gets bigger and bigger and bigger, taking up more room in the artery over time. And then there's also the potential risk that those plaques could eventually break off and become an embolus and get trapped in a major vessel occluding it, which could cause a heart attack or an MI or a stroke. So the process of atherosclerosis really starts after age 20 and keeps getting worse as we get older. And so it's not completely avoidable, but there are a lot of things that we can do lifestyle wise to slow down the process of atherosclerosis. So here's a visualization of what we were just talking about. So here, if in number A, in letter A here, we have some injury to the epithelium that happened from hypertension, from smoking, from high cholesterol, high blood sugars, different infections, toxins, things like that. So when the damage gets here, then those fatty deposits are going to start forming where that lining has been injured. And then in C, you can see here the fibrous plaque starts to form because collagen comes and covers the area. The vessel lumen now, or the space inside of the artery, is now limited, so blood flow gets reduced. And then platelets collect on top of it, right? Because the immune system is like, oh my gosh, there's an injury going on. Let me go fix it. And it's actually creating a worse problem, right? So this plaque can actually rupture. It creates a clot, right? The clot gets lodged somewhere else, creates an occlusion, and then patient has a heart attack or stroke. All right. So talking more about those fibrous plaques that are there, we usually see that people can start to develop these plaques around age 30. So I know people always like have fun and do what you want when you're a kid, but when you grow up, you have to stop eating all the junk food and you have to exercise and all of that stuff, right? So we really do, as adults, need to watch our cholesterols because it makes a big difference, right? So this slide is still going over some of the other things that we were just talking about how the plaques form and how the plaques can rupture, right? One thing that is a complication of long-term coronary artery disease is the development of collateral circulation. So what happens is, I'm going to skip ahead to this picture right here. What happens is that when the blood flow in an artery is occluded over time, because the body's natural programming is to create homeostasis, right? Is to make the body stable. And if the blood can't get through the artery, then the body will develop or grow new vessel pathways to go around or bypass the already established artery that's getting blocked. So you can see here, there's some narrowing here. So branches of these arteries are now growing together and forming new connections so that they can send blood around the occlusion, right? This collateral circulation is not great. It's it's, the body's best adaptation, but these new vessels are often really fragile. They can't take a lot of high pressure. And we've already talked about the arterial pressure is a lot higher, right, than venous pressure. So there's also risk of these new collateral circulatory vessels breaking and causing bleeds, which can be an emergent situation for the patient. So when we talk about coronary artery disease, there are many risk factors, a lot of risk factors. A lot of them are modifiable, are things that people can make lifestyle changes to address. But there are some that people are just born with and they are non-modifiable. These are things that we can't do anything about. Things like age, you're more likely if you're older to have CAD. If you can't do anything about the gender or the biological sex that you were born with. So men, once they get over the age of 45, and women over the age of 55 are at a very increased risk of developing CAD. Ethnicity can play a role. Genetically, African Americans have a much higher incidence than Caucasians or Asians with regard to CAD, which is similar to what we see with hypertension. So that makes sense. Family history, again, there is a big genetic link between people that have coronary artery disease in a family member that is an immediate family member. So a parent with them themselves also being at risk for developing coronary artery disease. Just think that some people are more prone to both having the endothelial layer break down and having those clots form, as well as having a genetic propensity for the different risk factors that can cause the breakdown of the endothelial lining, like hypertension, like diabetes, like high cholesterol. All right, in men, here are just some gender differences for you. It's more likely that the first time in a man that they experience angina, which is chest pain, that it is a heart attack or a myocardial infarction, which means that there's actual muscle death going on. Um, Men tend to report more typical signs of angina or chest pain and myocardial infarction, meaning that they're more likely to have typical just chest pain or pressure that radiates up to the jaw or down the left arm. Men receive more evidence-based therapies when they're actually ill from coronary artery disease. So that means that when men come in with chest pain, they're more likely to end up in the cath lab and having somebody look in their arteries. When women come in with chest pain, they're not as likely to be treated right away. And some of the thought is that people think, oh, they're just complaining. It's not a serious problem. Also, because sometimes we'll talk in a second about that women do sometimes experience symptoms that are a little bit different and harder to identify than male symptoms of coronary artery disease. Mortality rates from coronary artery disease have decreased more rapidly for men than women, which is good news for men, but not great news for women. Men tend to have larger diameter arteries, which is interesting. Vessel diameter is inversely related to risk for restenosis after interventions. What that means is because their arteries are already larger, if they go to the cath lab and they open up one of their vessels with an angioplasty or put a stent in, that men are less likely to have the hardening happen again in the areas where their artery was already opened up or stented. After 55, the incidence of MI in men and women equalizes. Men are more likely to develop collateral circulation, like we just talked about, the vessels growing around the narrowing of the arteries. And then standard screening for risk for sudden cardiac death is more predictive in men. So for women, it's more likely that the first time that they'll have symptoms of chest pain, pressure is not necessarily a myocardial infarction, but it's unstable angina. So they have a reversible ischemia, that chest pain that's signaling that the heart muscle is not getting enough oxygen to meet the demand, but there's no evidence that tissue death has occurred. So fewer women have classic symptoms. Fatigue is often the most common symptom of a myocardial infarction for women, but they tend to experience heart disease about 10 years later than men start to develop it overall. More often for women to have non-obstructive coronary artery disease. So it's more common that women will not have completely blocked arteries, just partial occlusions. Before menopause, women have higher HDL cholesterol levels and lower LDL. So HDL cholesterol is the cholesterol that's kind of heart protective. We call it good cholesterol. And then LDL is the bad cholesterol that causes the fatty deposits. But after menopause, the LDL levels start to rise in women and the HDL levels start to fall, which puts them at higher risk for an MI after menopause. That estrogen is really heart protective. Women report more disability after a cardiac event. They tend to seek medical care later in the coronary artery disease process, and some of that might be because their symptoms are not the classic symptoms. So they're more likely to have what we call a silent MI or have damage or death to the cardiac muscle in areas, but not realize that they have had heart attacks because they're not having classic symptoms. And often what we find is we have women that come in and have new onset heart failure. And when we investigate the cause of this new onset heart failure, we'll find out that it's actually because there's evidence that they had a myocardial infarction, but they didn't even know it. Women who have had an MI are more likely to have a fatal heart event within the next 5 years. Women who have coronary artery bypass graft surgery have a higher mortality rate and more complications after surgery than men. Okay. And then women are often undertreated with guideline-based recommendations, leading to worse outcomes and increased rates of readmission, reinfarction, and death in the first year after MI. That's really sad. Okay, so what are our major modifiable risks? What can we do? What are lifestyle changes or things that we can address with medication for patients to reduce their risk of dying from coronary artery disease? The biggest thing is controlling their lipid level. So we're going to be checking cholesterol levels on patients. And so the levels that we want to work toward as a goal is we want patients' total cholesterol to be less than 200. We want their HDL, which is the protective or good cholesterol, to be greater than 40 in men or greater than 50 in women. We want their LDL, which is often called the bad cholesterol that causes a lot of the fatty deposits, right? We want their LDL to be less than 130. We want their triglycerides, which are also very high risk for coronary artery disease, creating those fatty deposits. We want triglycerides to be less than 150. Okay. treatment guidelines for LDL are based on 10-year and lifetime risk. So there are calculators that providers use to determine what patients' risks are when they're deciding what their actual goals are for cholesterol numbers and which drugs to put them on. You guys are not going to be responsible for that, but just understand that the the goals that are set for patients are based on things like age, gender, race, if they're a smoker, if they have diabetes, if they have high systolic or high diastolic blood pressure, if they're already on blood pressure drugs, or have high total cholesterol or a low HDL level. So those things might put them at higher risk for developing CAD and make it more likely that a provider is going to put them on medication to lower their serum lipids. Hypertension is another huge risk factor for CAD, but very modifiable in most patients. So we, again, want them to maintain a fairly normal blood pressure, right? And we are going to help them meet that goal with lifestyle changes. We're going to advocate for them not to be smokers, not to be sedentary, having appropriate exercise levels, good heart healthy diets, and taking any blood pressure medications that are prescribed for them. So remember, over time, elevated blood pressure causes endothelial injury and leads to left ventricular hypertrophy because the pressure in the systemic circulation is higher. The left ventricle has to push harder against the pressure to get the blood out into the systemic circulation, which makes that left ventricle muscle grow bigger over time or get hypertrophied. And then the bigger the muscle gets, the less room there is for blood to fill and the less effective that oversized muscle is. It decreases the stroke volume, which is the amount of blood pushed into the circulation with each heartbeat, and then lowers the overall cardiac output for the patient. All right, tobacco use. Okay, so remember we talked about in musculoskeletal, it's not just the smoking, it's the nicotine. Okay, so nicotine increases catecholamine release, so epinephrine, norepinephrine. It causes increased heart rate, increased blood pressure, and peripheral vasoconstriction, all things that are not good for arteries. Okay. So we also find that use of tobacco is linked to increased LDL cholesterol, decreased HDL cholesterol, and an increase in toxic oxygen-free radicals that cause lining that cause damage to the endothelial lining and contribute to inflammation and blood clot formation in the arteries. The increased carbon monoxide is very dangerous if people are smoking tobacco. So we've talked before when we talked in respiratory about that carbon monoxide mimics oxygen, and so it can bind to hemoglobin and take up space that's supposed to be for oxygen transport, so it can decrease perfusion even when it's not necessarily decreasing the amount of blood or cardiac output that's getting pumped out of the heart. There may not be as much oxygen available because it's containing carbon monoxide from the smoke. Secondhand smoke causes increased CAD risk. There's about a 25 to 30% increased risk of CAD with secondhand smoke exposure. And research has shown that when people quit smoking, the benefits are quite dramatic. So it does make a big difference in people's outcomes. So we really need to advocate for that. Diabetes and insulin resistance, again, a very modifiable risk factor. People can't always control if they have diabetes, but it is something that we can manage very well with diet, exercise, and we have various medications these days. So that's why we're saying that this is a modifiable risk factor, right? So people with diabetes are up to 4 times more likely to develop coronary artery disease. They have increased endothelial dysfunction because of their altered lipid metabolism. Increased cholesterol and triglycerides is very common with these types of metabolic disorders. And people um, that don't qualify as being diagnosed as diabetes, but still have some insulin resistance and qualify for this generalized syndrome called metabolic syndrome, are also just as at risk for developing CAD as people that are diagnosed with diabetes. Metabolic syndrome is marked by people that have obesity, hypertension, high cholesterol, and high blood glucose. Exercise, physical activity, and obesity, both very, very important modifiable risk factors for coronary artery disease. And remember that carrying extra weight in your abdomen and having that apple shape, that larger waist circumference, is actually much more predictive of developing coronary artery disease than having like the pear figure where people have like the bigger hip measurement, but their waist is still small. Research has just shown that people with both elevated BMI and a large waist circumference are just at higher risk. We also know that psychological states, so anxiety, stress, depression, things that increase sympathetic nerve stimulation that release the catecholamines like epinephrine and norepinephrine, are very hard on arteries over time. So also people that are like constantly under stress because they have like the type A kind of perfectionistic, very high standards for themselves, make it very hard to live up to expectations for themselves, personalities, very controlling, often are at higher risk for developing coronary artery disease. And then substance use. So we know that things, again, that really stimulate the sympathetic nervous system, amphetamines, like cocaine, methamphetamine, can produce also coronary spasms, which when the arteries are spasming, it cuts off circulation to the cardiac muscle the same way that a clot or an occlusion would, so it can still cause a myocardial infarction. All right, so here's a practice question. 2 risk factors for coronary artery disease that increase the workload of the heart and increase myocardial oxygen demand are obesity and smokeless tobacco, hypertension and cigarette smoking, elevated serum lipids and diabetes, and physical inactivity and elevated homocysteine levels. And the answer is B, hypertension and cigarette smoking. Another practice question, which patient is most at risk for developing coronary artery disease? A patient with hypertension who smokes, an overweight patient who uses smokeless tobacco, a patient with diabetes who uses methamphetamines, and a sedentary patient with an elevated homocysteine level. And the answer is A. So hypertension is like lipids, hypertension are the biggest predictors of CAD, and then smoking is one of the biggest modifiable factors as well. So these are all factors that can put patient at risk, but a patient who has hypertension and who smokes is at the highest risk. Okay, the nurse determines that teaching about implementing dietary changes to decrease the risk of coronary artery disease has been effective when the patient says, I should not eat any red meat such as beef, pork, or lamb. I have some type of fish at least 3 times a week. Most of my fat intake should be from olive oil or the oil in nuts. If I reduce the fat in my diet to about 5% of my calories, I will be much healthier. And we know that the teaching is effective if the patient says, C, most of the fat intake in my diet should be from natural sources like olive oil or the oils in nuts. So we want to stay away from saturated fats. All right. So, how do we treat coronary artery disease? So, the biggest thing besides lifestyle modifications is statin therapy. So, statins are drugs that work to reduce the LDL, increase the HDL, and lower overall inflammation in the body. Okay. Examples of these are atorvastatin, which is known as Lipitor, rosuvastatin, which is known as Crestor, and simvastatin, which is known as Zocor. There are some serious side effects to these drugs. However, they are very rare, but we have to monitor patients for these things. They can cause liver damage, so we don't want to start anybody who already has some liver issues on these medications. And then some people do rarely report that it causes myalgias, which is muscle pain, particularly in the legs. So we really have to be careful and monitor that. Okay. So patients with known cardiovascular disease that have an LDL cholesterol greater than 190 usually are um, really prime candidates for statin therapy. And if they're older adults over 40, I hate to say older adults over 40 since I'm in that group. But if they have diabetes, we're going to start them on a statin when their LDL is much lower than the 190 limit because they're already at such higher risk to develop CAD. When we add in diabetes, we really want to keep their LDL cholesterol level down. So if they get to be over, say, like 70 on their LDL, then their provider may consider starting them on a statin, depending on what their overall 10-year risk is for developing cardiovascular disease. And that has to do with those calculators that we were talking about, again, taking into account the other risk factors that they have. All right, so more about statins. Statins are also known as HMG-CoA reductase inhibitors, but we will just refer to them as statins. So they are lipid-lowering drug therapy, and patients typically, once they are started on these, they have to stay on them their whole life. So the goal is for these drugs to bring the lipids down, but if patients get their lipids under control and stop taking them, their cholesterol levels just go right back up when they stop taking them. So we really have to teach people not only about what the goals are, but we have to explain that this medication will make their numbers really improve. But if they stop taking it, their numbers will go back to being poor again. We need to educate them about potential side effects of these medications because they can be dangerous, and we need for them to report to us any muscle pain, cramping, particularly in the legs, any abdominal pain, particularly on the right-hand side of their body. We need to make sure they understand that the drug won't do all the work, that they have to have positive diet changes, have a heart healthy diet that is low in saturated fats, and low in sodium, and that they need to increase their physical activity. And then we're going to plan to reassess them in like between 1 and 3 months or 4 to 12 weeks. And if we check their lipids again and they're still high after a few months, then we're going to either change their dosage if we can, or we're going to switch them to a different statin drug. So there's lots of different statin options, and some work better for people than others do. So sometimes we need to switch to a different, some of the statins are a little bit more aggressive, and so we can switch to those. So alternatives to statins. So some people, like I said, that have serious side effects or have pre-existing issues with their liver, can't tolerate statins, or some people just refuse the statins, don't want to take them. We have some other options that we can do. We can offer the patient to take some niacin, which has been showed to lower triglycerides, and it mildly reduces LDL cholesterol. If they take a lot of niacin, it can raise their HDL a little bit. A lot of patients do not like taking niacin because for most people, when you take it, it causes severe flushing of the face and itching of the skin and can cause GI upset and orthostatic hypotension. So has a lot of potential side effects. Um, Fibric acid derivatives, these are medications like fenofibrate and gemfibrozil. These medications are really great at removing triglycerides, and sometimes the statins themselves don't do a fabulous job at bringing down triglyceride levels. They do a better job on LDL cholesterol and total cholesterol. So for some patients, they may add in one of these medications, these fibric acid derivatives, in addition to their statin to also bring down their triglyceride level. ATP citrate lyase inhibitors, like a medication called Nexletol, help lower LDL in patients that have a family history of high cholesterol. Um, and we sometimes will try this if they're not getting good enough cholesterol lowering of their LDL with just the statin. But a problem with this drug is that sometimes patients that have a history of gout, it can exacerbate their gout, which is formation of uric acid crystals in their joints, which can be very, very painful. And then very rarely it can cause tendon rupture, which would be terrible. Bile acid sequestrants. So these are drugs like cholestyramine, and you'll typically hear this referred to as by the trade name as Questran or Welchol. These are medications that help convert cholesterols into bile acids and reduce the total LDL. It decreases the absorption of a lot of other drugs, though. So if somebody's on a lot of other medications, it can reduce the effect of other medications they're on. So we don't see these drugs used as much anymore, but we can sometimes see this with patients that have um, issues with taking statins and can't tolerate them. All right, and then these drugs are new. So these are referred to as PCSK9, and they are drugs that are injectable drugs to lower LDL. They're very new on the market and they're not in very wide use right now. So all that you really need to know is that the goal of this drug is to lower the LDL or the bad cholesterol level, and that it's an injection. It's the only option on this drug list that is an injection. It's a subcutaneous injection that they would take 1 to 2 times a month. All right. Drugs that decrease cholesterol absorption. This is Zetia. So very common for us to see patients on a combination of this drug and one of the statins. It selectively inhibits the absorption of dietary and biliary cholesterol. So the statin works to reduce the LDL level, and the cholesterol absorption drug blocks some of the cholesterol from ever even being absorbed in the GI tract. And so people are um, excreting a lot of the fat in their diet through their stool. Antiplatelet therapy. So, because people at high risk of developing coronary artery disease are at risk of plaque formation in their arteries, a lot of times we will recommend that they be on low dose aspirin, which is an 81 milligram, also known as a baby aspirin, daily because of its antiplatelet properties. So it helps platelets to not stick together and not aggregate on those fatty streaks that are deposited to try to limit plaque formation. But it does can increase the patient's risk for bleeding, so if it may not be appropriate for all patients. All right. Gerontological considerations with coronary artery disease for older people, it is over 65. It is the leading cause of death. Strategies to reduce CAD are very effective. That means that we need to really advocate to our older patients to aggressively treat and adhere to their treatment plans for high blood pressure, high cholesterol. They need to stop smoking. They need to stay physically active and eat healthy diets. Older adults are most likely to change their habits when they are hospitalized with chest pain. So, younger people are more likely to have episodes of chest pain and then be in maybe a little bit of denial about it. Like, well, I'm still young, I have time, like, I don't have to be that serious about it right now. But older people kind of have that realization that I'm older, I might not have that much time left, and this could be like a wake up call. So, our older patients that come in with chest pain are usually pretty agreeable to learning about what they need to do to maximize the time that they have. All right, so we're going to talk about symptomatic coronary artery disease, which is called chronic stable angina. Okay, so coronary artery disease is chronic and progressive, and for a long time, people won't have any symptoms of it. They won't know that they have hardening in their arteries or plaque formations. And then all of a sudden, people will start experiencing episodes of chest pain. Chronic stable angina happens when the oxygen demand from the coronary muscle, from the heart muscle, is greater than the coronary arteries can supply with the cardiac output that the heart is pumping. Another term for this that you may hear in the clinical environment is demand ischemia. Okay, so the muscle of the heart is not getting enough oxygen or enough perfusion for the work that it is being required to do from the coronary arteries. Okay, and they're not able to perfuse enough oxygenated blood. Okay, so the demand is greater than the supply. Okay. And the clinical manifestation of that demand ischemia is angina, which is chest pain. Okay. Typically, when people have experience symptomatic CAD, which is the chronic stable angina, it typically means that they have one or more arteries that are blocked up to 70% by atherosclerotic plaque. Um, or less if it's the left main artery. When the left main artery is blocked by about 50%, people typically start to experience angina. All right, so with chronic stable angina, people are symptomatic during physical exertion when their heart is under stress, and that stress can either be physical or emotional. So, the acronym that we use to do assessment for chest pain is PQRST. So, that stands for provocation, what makes it work? Quality, what does it feel like? Is it sharp? Is it stabbing? Is it dull? Is it pressure? Region, where are you feeling the pain? That can be very important, especially to ask women because they don't always have that classic substernal chest pain complaint. The severity, rate it on a scale of 0 to 10. And then timing, how long is it lasting for? Okay. Is it happening after you eat? Is it happening after you exercise? Is it happening while you're asleep? Right? So sometimes if you use the words chest pain, people will say, I'm not having chest pain. They'll say it just feels like pressure or heaviness. A common saying that people use to describe angina is it feels like an elephant is sitting on my chest, right? So it can also be accompanied by shortness of breath and fatigue, and no change in position or amount of breathing makes it feel better. So here are common locations and patterns of chest pain that people complain of. Mid sternum would be in the middle of the chest here, and then in the jawline area of the neck. And then substernal, we kind of say is up and down the center of the chest and then under the jawline. Epigastric goes a little bit below the sternum area, right at the top of where the stomach is. And then intrascapular is when people complain about it being right between their shoulder blades on their back. All right. Chronic stable angina typically lasts a few minutes and it usually subsides when people either take a direct vasodilator like a sublingual nitroglycerin tab or nitroglycerin spray, or they rest and sit down. When blood flow catches back up, when perfusion catches back up to the demand of the heart muscle, that pain or pressure feeling goes away. When we look at 12 lead EKGs on these patients, we see ischemic changes, which means there is depression of the ST segment or T wave inversion. And we'll look at in a few minutes what that looks like. When the blood flow is restored, either by taking a vasodilator or resting, the pain is relieved and the changes on the 12 lead EKG will go back to normal or baseline. Okay. Some people have silent ischemia, like we talked about. This would be CAD that is asymptomatic. Okay. A lot of times, patients with diabetes that's advanced and have diabetic neuropathy, and so they have numbness to different areas of their body because their nerves are not sensing pain the same way that they used to, related to damage of those neural pathways from the high glucose levels in their blood over time. They may not feel the same chest pain or pressure that other people do, even though their EKG might show that their heart is being deprived of oxygen. Okay, Prinzmetal's angina. This is also known as variant angina or vasospastic angina. It is a rare type of chronic stable angina that happens at rest. So, say somebody is just watching TV and all of a sudden they start having chest pain or pressure that happens for a few minutes and then resolves and it goes away. And that keeps happening over and over again. This is related to spasms of the major coronary arteries. It can happen to people that don't have coronary artery disease as well. Some people that have history of migraine headaches or Raynaud syndrome, or have a history of being heavy smokers may experience this. Um, but there's really we don't always know what causes Prinzmetal angina or variant angina. And again, it's very rare. But just so you guys have an idea of what it is, it's not necessarily caused chest pain that is not necessarily caused by blockages of arteries. It's caused by spasms of the major coronary arteries. Okay. When people experience this, we encourage them to stay active. And if they know what precipitated it, if there's something they do or a drug they use that causes this, then we tell them to stay away from those things. And then we probably will still maybe give them some nitroglycerin to keep at home to try to dilate the arteries when it's happening. Sometimes they'll be put on a calcium channel blocker medication. Microvascular angina is another type of cardiovascular disease that can cause stable angina because the the blockages in the atherosclerosis are in the very smaller or distal branches of the arteries. And so if we look at the major coronary arteries, like if we did a heart cath, we wouldn't see those big blockages in the big major arteries. We would see a lot of smaller blockages in smaller arteries that are causing chest pain with exertion. It's more common to happen in women. And the prevention and treatment is the same as coronary artery disease. It still is coronary artery disease. It's just affecting the smaller vessels as opposed to the large coronary arteries. All right, our nursing goals for chronic stable angina are to reduce the demand of oxygen that the heart needs and increase the supply, right? So again, chronic stable angina, demand ischemia. The demand for oxygen of the cardiac muscle is higher than the supply of oxygen in the blood that's perfusing the heart through the coronary arteries. So we just need to try to reverse that, reduce the demand and increase the supply. We can do that with supplemental oxygen and encouraging periods of rest, managing anxiety. We can have the patient do diagnostic studies. We can find out if there are any blockages or areas that need to be addressed so that we can get them more blood available to the cardiac muscles. Sometimes that means giving them nitroglycerin tablets that are direct vasodilators to use at home, and they're very fast acting. So our main goals for nursing are going to be pain relief, making sure that they're on the most appropriate treatment and that we get treatment started right away. That our biggest goal is always preserving heart muscle. If we think that an MI is suspected, we're going to activate the emergency system and get the patient into the cath lab for them to investigate if they can open up arteries right away if needed. We're going to assess if they have effective coping skills and give them referrals to support if they need it. Hooking them up with cardiac rehabilitation programs so they can learn safe exercise programs and be monitored safely for their cardiac status while they're exercising. And then we're going to do really good education about modifiable risk factors and help them reduce those risk factors. So better diet, appropriate exercise, no smoking. All right, here are some interventions. We're going to position patients upright, apply oxygen. We're going to assess vital signs, heart sounds, and breath sounds. We're going to watch continuous telemetry monitoring and take 12-lead EKGs if we suspect any changes. We're going to make sure that they have pain relief, nitroglycerin to create vasodilation. We can also use IV opioids like morphine or Dilaudid, which is hydromorphone, if we need to, if their pain is high, to help bring down their stress level on their heart. And also it can provide some vasodilation. We're going to get some blood samples for them so we can check on cardiac biomarkers like troponin, which we'll talk about when we talk about acute coronary syndrome. We can look at chest x-rays to see if there's any evidence of enlargement of the heart or infiltrates in the lungs, anything like that. We're going to help do things to reduce their anxiety, whether that's emotional support, talking to them, providing distraction, or actually giving them medication to help reduce anxiety. And then we're going to do really good patient teaching about how to identify and avoid precipitating factors, how to reduce modifiable risk factors, how to have a successful cardiac smart diet plan with low sodium and low saturated fats. We're going to encourage appropriate physical activity to work toward getting to an ideal body weight, taking their medications and knowing what all their medications are for, and then psychological support to make sure that they know that they have help and can learn coping strategies. All right, different drugs that we use to deal with chronic stable angina would be antiplatelet therapies like aspirin, short-acting nitrates like nitroglycerin, and the way that we give that is we give them a tablet or a spray under their tongue, and then we wait 5 minutes. And then if it's not helping within 5 minutes, we can repeat if we're in the hospital. If they're out in the field, at that point, we would be calling 911. Because they are potent vasodilators, we need to remember that nitroglycerin can cause headache, dizziness, flushing, and orthostatic hypotension. We need to make sure patients know how to store and use their nitroglycerin properly, and we can teach them about prophylactic use. So if they know that they're going to do something that's going to be very physically asserting and they're going to create a high demand on their heart muscle, that maybe they take a nitroglycerin tablet before they do that. Long-acting nitrates are also available. Patients that have the Prinzmetal's angina, which is the coronary spasms, often use longer-acting nitrates. We're still going to use nitroglycerin, but instead of the sublingual, we'll either take an oral pill that you swallow and is absorbed in the GI tract, or we will have an ointment or paste that goes on the patient's chest, or a transdermal patch. We use ACE inhibitors or ARBs to promote vasodilation and reduce blood volume by limiting the amount of salt and water that are retained, kind of breaking up that RAS system. We're going to use beta blockers to decrease the contractility of the heart and the heart rate. and also helps reduce the systemic vascular resistance and blood pressure. So we do have to always, as we learned with our hypertension lecture, we have to monitor for both bradycardia and hypotension, and we don't want to give beta blockers to somebody that has moderate to severe asthma, right? So we want to be aware of that. And then we also might give calcium channel blockers because they encourage systemic vasodilation and reduce the systemic vascular resistance. Again, we need to, whenever we're giving vasodilating drugs, we need to make sure patients are aware that it can cause fatigue, headache, dizziness, hypotension. With the calcium channel blockers, if the patient also has heart failure, taking a calcium channel blocker with digoxin can increase the effects of the digoxin. So we just need to be aware of that if they are, we just want to know if they're taking digoxin so we can report it to the provider. All right. Sodium current inhibitors are used when there's inadequate response to other anti-anginal drugs. These are not used very often. Ranelazine and mexiletine. These drug names drive me crazy. Sorry, guys. These are not common drugs. So just know that they're out there as an option. If all else fails, we'll try these, but they're not commonly used drugs. Okay. And then you can review the CAD meds. We also use the statins, lipid lowering drugs with chronic stable angina. All right, diagnostic studies that we'll use to evaluate chest pain are 12-lead EKG. We'll look at blood levels of troponin, their lipids. CRP gives us an indication about overall inflammation in the body. Chest x-ray, echocardiogram, exercise stress test. So we'll have the patient do a baseline EKG or echocardiogram, and then we'll induce stress either with them jogging on a treadmill, or we'll give them a drug like dobutamine that induces stress on their heart. And then we'll redo the EKG or the echocardiogram to see if there was a difference after the stress. We can do CT scans or cardiac MRIs, but the gold standard of evaluating chest pain is to do a cardiac catheterization. So we can do an angiogram, which is just visualizing diagnostically to see if there's anything going on. And then they can intervene and open the blockages with a balloon and place a stent to keep it open if necessary, which is called an angioplasty. So angiogram is the diagnostic just viewing to see if there are blockages, and intervening with the balloon catheter or placing of stent, which is like a coil that keeps the artery open, is an angioplasty. And stents can be bare metal or drug eluting. All you need to know at this point, you'll learn more in fourth semester about the ins and outs of this stuff, but at this point, just know that there are metal or drug eluting stents. All right, this is what it looks like when they place a stent in your patient. Okay, so they go in with the catheter, they visualize where the plaque is. You can see in A right here. And then they're going to use a balloon to blow up and kind of push the plaques to the side. And then they deploy this little mesh stent that looks like a little coil, and it stays in there like a little spring, and it holds the artery open. So the plaque's not going away, right? They're just kind of moving it to the side and creating some more infrastructure for the blood to flow through. Okay. So here are some pictures. This is right coronary artery occlusion on a patient. You can see here the blood flow is very restricted here. And then after the angioplasty, where they've opened up the artery, you can see how much more blood flow is coming through there now. The term that we use overall for invasively going through an artery, either in the groin or the wrist, into the coronary arteries with the camera, and is called PCI, or percutaneous intervention. So an intervention going through the skin. So when it says PCI, that's percutaneous intervention, which means going to the cath lab and having an angiogram and or angioplasty. Okay. So stent placement procedure, post and during procedure drugs. Just know that drugs are used to prevent platelet aggregation and stent thrombosis both during and after the procedures. Typically, patients are either put on heparin or a direct thrombin inhibitor, which is a drug like integralin, which is an IV drip. After the intervention, patients will be put on dual antiplatelet therapy, which is abbreviated DAPT, which is a combination of aspirin and a medication called clopidogrel, which is known as Plavix. All right, nursing management of the patient that has gone to cath lab. Before the patient goes into the cath lab to get a percutaneous intervention, or PCI, we're going to make sure that they don't have any contrast dye allergies. So we're checking for allergies to iodine and or shellfish as well, because those are iodine-based allergies, and our contrast dye is that we need to be able to visualize the veins is iodine-based. We need baseline vital signs, pulse ox, heart and breath sounds, neurovascular assessments, making sure they're not having any numbness or tingling, that they can move their extremities. We're going to look at their labs. We're going to look at, we're going to see if they need any medications. So if they take any regular medications that can't be missed, sometimes we'll give them additional fluid, or sometimes they'll have the patient started on the antiplatelet or anticoagulants before the procedure as well. After the procedure, the nurse's main job is going to be to monitor the patient's heart rhythm for any dysrhythmias, making sure that their IV medications are going for whatever blood thinner or antiplatelet that they're on, making sure that we're controlling any chest pain that might be residual from after the cath. And then big time, we're also going to make sure that we're monitoring for any bleeding, because there's so much anticoagulation being used, and they're accessing the patient's vasculature through an artery. So particularly if they have a groin site, because the femoral artery is a big artery, we don't want any bleeding to happen. High pressure bleeding will incur from that arterial site. So we need to monitor those sites very closely. If they went in through the radial artery, it's not as high of a risk of bleeding, but we still need to monitor it closely. So patients that come back from cath lab need to be monitored every 15 minutes for at least the first hour. And then after that, most places will still have you monitor them every 30 minutes for an hour after that, and then once an hour for the next 2 hours after that. All right. And then another option, if the PCI doesn't work, so we've tried doing the balloon catheter to open up the artery, we've tried putting stents in. If that doesn't work, then patients are going to need to be referred for open heart surgery to do a coronary artery bypass graft, also known as a CABG. What that means is, in order to get the perfusion to the cardiac muscle that is needed, they're going to have to harvest artery or vein from another part of the body, typically the leg, and then they will cut the pieces of those arteries, take them, and then sew them or graft them on to the heart to create a collateral circulation. So they're creating a new coronary artery, right? So it's very high risk because it is open heart surgery. So we need to really watch our patients for so many things, infection. So here's a picture. You can see here's like a graft that they would put from a larger part of the artery, bring it down and sew it to below where the blockage is if they're not able to clear out that blockage, right? So if the blood flow is getting to here and then stopping, they'll put the graft right below the obstruction so that the arteries feeding the muscle below the obstruction are still getting perfused with oxygenated blood. Um, so we talked about that the grafts usually come from the leg. There are some alternatives to traditional cabbage. I'm not really that concerned with you guys. This is just like interesting to know. I'm not really going to go over it much. Just know that if because people have to be put on bypass machines and we have to basically, almost like take all the blood out of their heart to be able to do this surgery. It's extremely complicated. So if patients can't tolerate the cabbage procedure, there are things that are a little less invasive, but they are not as successful in the long term for patients. So if PCI fails, if stenting fails, the gold standard really is to move toward a cabbage. All right, after patients have cabbage surgery, you're going to learn in fourth semester about taking care of post-open heart patients. For right now, you just need to understand that these patients are going to go directly to the ICU after open heart surgery for about a day or two, sometimes a little bit longer, because they'll be on a ventilator when they first come out. They'll have an arterial line, all of that stuff. You guys don't need to know about it now. All of this stuff you'll learn about in fourth semester. So just know that they're going to go to the ICU for the first day or two, and then they'll step down to like a DOU type unit. Some places call it progressive care or step down or a cardiac telemetry unit. And then they'll typically be in the hospital for about a week total. All right, so we really want to watch after bypass surgery, monitor for systemic inflammation, any bleeding, any signs of anemia, fluid and electrolyte balances, infection, both to the grafting harvesting site in their leg or wherever it was, and to their chest. And then we want to watch for hypothermia. We want to watch their temperature control can be of their body can be altered after open heart surgery. We absolutely want to monitor on continuous telemetry for any dysrhythmias, especially atrial fibrillation is very common after open heart surgeries. And then again, wound care, monitoring for infection, making sure dressings are clean, dry, and intact. We want to take care of patients' pain. Remember, we need them to do coughing and deep breathing. We're going to have to teach them about splinting with pillows and using their incentive spirometers to keep their lungs really inflated to avoid pneumonia, but their pain level from having a huge incision in their chest and having their ribs spread open is going to impact their ability to do those things. So we need to make sure we're aggressively treating their pain. We need to make sure we're doing VTE prophylaxis, so ambulating early, having SCDs or TED hose on, and then we need to make sure that we are being mindful of their cognitive status. When patients have episodes of delirium in the ICU, patients are at high risk to have what is similar to like a very mild brain injury. known as postoperative cognitive dysfunction. So some people never feel like they really get their full cognitive abilities back. They'll always feel a little foggy and slow after stays in the ICU on ventilators, especially if they have episodes of delirium. So we need to do what we can to reduce those things. All right. So for Um, people that have chronic stable angina that is refractory to treatment, so means we've tried lots of different treatments and nothing is getting rid of the chest pain, we can do something called EECP, which is enhanced external counterpulsation. It's a technique where we kind of are trying to trick their brains in a way, and we use these inflatable cuffs around their legs, and it's supposed to increase venous return, so it creates compression. It can help improve diastolic filling. Um, and it sort of like tells their brain also to switch off the pain signal that's causing their chest pain. It's not indicated for people that have decompensated heart failure, so CHF exacerbations, or severe peripheral vascular disease, or severe aortic insufficiency, which is a problem with a leaky aortic valve. Okay, this is not a super common treatment, and there's not a whole lot of evidence that it's a great treatment, but when nothing else is working, it's something that we can try. All right, so that's it for this one. I'm going to break it up into a separate lecture. So come back for acute coronary syndromes and we'll talk about MIs.